Welcome to Board Pearls. This is episode 2 of 3 of the Esophageal Symptoms and Diagnostic Workup chapter in the Esophageal Disorders module. This episode is the esophageal complaints that aren't classic dysphagia, globus, rumination, and the functional pain problems, and then painful swallowing, which you work out from what the patient was exposed to. The dysphagias that come after surgery or from a systemic disease are episode 3. There's one thing that ties all of the first group together, and it's worth holding on to, because it changes how you listen. These are the patients whose scope and reflux workup already came back clean, so the test isn't going to hand you the diagnosis here. The history is. And there's a recurring tell across the whole group. A patient who looks like reflux on the surface but doesn't get better on a real dose of acid suppression is telling you the problem was never acid. Every time that happens, stop escalating the PPI and rethink the diagnosis. Start with globus. The patient feels a lump or tightness in the throat, and the key detail is that it's there between meals, when she isn't swallowing anything, and that swallowing food or water doesn't make it worse, it actually eases it or leaves it unchanged. That's the opposite of real dysphagia, and the contrast is the whole point. Real dysphagia gets worse when you swallow because the food has nowhere to go, while globus gets better or stays the same because there's no blockage at all, just a heightened awareness of a normal throat sensation. Because there's no lesion driving it, the workup stays narrow. Ask about reflux and postnasal drip. Examine for them and go looking for a structural cause only if there's a warning sign, real dysphagia, weight loss, hoarseness, a neck mass, or a smoking history, in which case an ENT exam clears the larynx and hypopharynx. Once that screen is clean, reassurance is the actual treatment, not a way of stalling, because this is benign and pushing harder rarely helps. And a PPI isn't the reflex answer, because the problem isn't acid. Rumination is the one that looks like reflux and fails a double dose of PPI for a reason you can explain. A young patient brings food back up after nearly every meal, starting 10 or 15 minutes in, and the details are what give it away. It's effortless. There's no nausea and no retching beforehand. The material is the food she just ate still recognizable, and she chews it and either swallows it again or spits it out. She's usually been on high-dose acid suppression with no benefit, and she's gained weight rather than lost it. What's actually happening is a learned, unconscious squeeze of the abdominal wall and diaphragm that raises the pressure in the belly against a relaxed lower sphincter, and that pressure pushes undigested stomach contents back up. The formal criteria ask for effortless regurgitation of recently eaten food on most days for at least 3 months, with the problem present for 6 and no retching before it. You confirm it with a pressure and impedance study after a meal, where you see the giveaway, belly pressure and esophageal pressure rising together in the period after eating, often with the sphincter opening at that same instant, which is neither reflux nor vomiting. The mistake is to keep pushing acid suppression, because she's bringing food up after meals. This is a behavior, not an acid problem, and it's not a broken anti-reflux barrier either, so neither more PPI nor fundoplication is the answer. The fix is diaphragmatic breathing, taught by a behavioral therapist, and the reason it works is mechanical. Slow, deep belly breathing after a meal is physically incompatible with the abdominal squeeze that drives the event, so you can't do both at once. Cognitive behavioral therapy gets added when it's stubborn. Supragastric belching belongs to the same behavioral family. The patient pulls air into the esophagus and immediately pushes it back out in a learned loop that happens while awake and disappears during sleep or during conversation, and it responds to the same breathing retraining that helps rumination. Functional chest pain is chest pain where you've genuinely ruled out the heart, reflux, eosinophilic esophagitis, and a primary motility disorder with the right tests. What's left is an oversensitive esophagus, where the nerves carrying signals from the esophagus and the brain's pain processing are turned up too high. So ordinary events, a little reflux, a normal contraction, mild stretch, get red as pain. The temptation, because it sounds like reflux, is to push the PPI dose higher when a standard dose fails. And that's wrong, because the problem is in the pain pathway, not in how much acid is there. So the answer is a nerve signal modulator. A low-dose tricyclic like imipramine or amitriptyline at 25 to 50 milligrams at bedtime, first line, with an SSRI as an alternative if that's better tolerated, and hypnotherapy or CBT as reasonable options for someone who'd rather not take a drug. The class to reach for is the neuromodulator, not a bigger PPI. Functional heartburn and reflux hypersensitivity are the same idea on the heartburn side, and they're detailed in the GERD chapter, but the pattern is worth naming here. Functional heartburn is heartburn with normal acid exposure and no link between symptoms and reflux events, and it's treated with a neuromodulator. Reflux hypersensitivity is heartburn with normal acid exposure, but a clear link between the symptoms and ordinary reflux events, so the patient really is feeling physiologic reflux that's below the amount that counts as GERD, and it's treated with a neuromodulator plus acid suppression. The framework that separates these from true GERD is in Chapter 3. Now, painful swallowing. Odynophagia. The rule is that pain on swallowing means the lining is injured until proven otherwise, and you narrow it down by what the patient was exposed to before you ever scope. 3 exposure questions do it. Did they swallow a pill with too little water or lying down? What's their immune status, meaning HIV and the CD4 count, transplant, chemotherapy, or long-term steroids, inhaled or systemic? And is there a history of bad reflux or a caustic ingestion? Pinning the exposure usually gets you to 1 or 2 diagnoses before endoscopy, and then the scope goes in aimed at the right spot to biopsy. Pill esophagitis is direct chemical injury where a tablet sat against the wall. Pills hang up in 2 predictable places, at the level of the aortic arch, where the airway indents the esophagus, and at the lower sphincter, where a slow wave can leave a pill parked against the wall for minutes. The damage is local toxicity from the dissolving tablet, so it depends on the drug's chemistry and how long it stayed in contact. The usual offenders are doxycycline and tetracycline, potassium chloride, especially the extended-release form, the bisphosphonates like alendronate and risedronate, NSAIDs and aspirin, iron, clindamycin, vitamin C, quinine and quinidine, and dabigatran. The risk factors all come down to contact time, a pill taken with little or no water, taken lying down, or held up by a motility problem or a stricture. The classic story is sudden pain, behind the breastbone, hours to days after a specific pill. The young person who took doxycycline for acne at bedtime with a small sip of water. The scope shows discrete, often shallow ulcers at the aortic arch level with normal lining in between, and paired ulcers kissing on opposite walls are the giveaway. Under the microscope, it's an ulcer with ordinary inflammation, no eosinophils to suggest eosinophilic esophagitis, and no viral changes. You treat it by stopping the drug, coating the injury with a sucralfate slurry, and teaching pill technique. Upright with a full 8 ounces of water, staying upright for 30 minutes. Add a short PPI course if there's reflux alongside. It settles in a week or 2. Infectious esophagitis is where the host tells you the organism before the scope does. Candida is the most common, and the hosts are the ones with weakened local or general defense. The PPI user on an inhaled steroid, the HIV patient with a CD4 under 200, the transplant recipient, someone on long-term broad-spectrum antibiotics, and the patient whose esophagus doesn't clear itself because of achalasia or a stricture. It's overgrowth of the yeast that normally lives there once defenses drop. The scope shows white or yellow-white plaques stuck to the lining that don't wash off, and brushing show the yeast and its filaments. Treatment is fluconazole, 200 to 400 milligrams a day for 14 to 21 days, with an echinocandin when resistance is known or likely, especially in a transplant patient who's had azoles before. The 2 viral ones are worth learning as a pair because the recognition and even the biopsy site mirror each other. Herpes shows shallow ulcers with raised, sharply cut edges, the so-called volcano edge, in the mid to lower esophagus, and the infected cells, multinucleated giant cells with the Cowdery inclusions, live in the squamous lining at the ulcer's edge, so you biopsy the edge. Treatment is acyclovir, 400 milligrams by mouth 5 times a day for 14 to 21 days in the immunocompromised patient, intravenous when they can't swallow, with Foscarnet for resistant virus. CMV shows the opposite kind of ulcer, one or a few large, deep, often snaking ulcers low in the esophagus, sometimes called punched out, and its infected cells, the ones with the owl eye inclusions, sit in the deeper tissue at the ulcer's base, so you biopsy the base. So hold the pairing. Herpes lives at the edge, CMV lives at the base, and forgetting that is exactly how you biopsy the wrong spot and miss the organism. The host that points to CMV is HIV, with a CD4 under 100, transplant or neutropenia from chemotherapy. Treatment is intravenous ganciclovir, 5 milligrams per kilogram twice a day to start, then oral valganciclovir to finish, with Foscarnet for resistance. Chapter 5 carries the fuller workup, including when to skip empiric fluconazole and scope straight away, which comes down to severity, immunocompromise, no response to fluconazole, or a picture that looks viral or pill-related rather than yeast. So the theme of this episode is that the diagnosis is made from the history, and the test just confirms it. A reflux-looking patient who doesn't respond to real acid suppression is the signal that it isn't reflux. Globus gets reassurance, rumination gets breathing retraining, functional chest pain gets a neuromodulator, and functional heartburn and reflux hypersensitivity gets sorted out by their acid exposure profile in Chapter 3. And painful swallowing gets worked out from 3 exposures: the pill, the immune status, and prior injury before you scope, with the biopsy site being what separates herpes from CMV. That leaves the dysphasias the standard workup misses, because the answer isn't in the scope report. Episode 3 takes those, the ones after fundoplication and bariatric surgery, where a barium swallow showing the anatomy comes first, and the ones driven by a disease outside the gut, with the manometry pattern of scleroderma as the one to carry forward. For the full chapter, the practice vignettes, and the topic tag question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 2 of 3 of chapter 1, and I'll see you in the next one.